So for our next talk, we're going to hear about a project that leverages not only EHR data, as in the last presentation, but also genetic data from the Million Veteran Program. So for this, we'll be hearing from Dr. Joy Shi. Dr. Shi is an epidemiologist and assistant professor at the Mongan Institute at Massachusetts General Hospital and CAUSALab at HSPH. She's interested in target trial emulation, causal inference methods, particularly instrumental variables, and pedagogy. Her research focuses on applications of target trial emulation and improving causal inference methods to answer clinically relevant questions about the treatment and prevention of chronic diseases. So welcome, Dr. Shi.
All right. Thank you very much, Dr. Dickerman, for the introduction, as well as the invitation to speak today. As discussed, what I'll be highlighting today is some of the work that leverages the biobank data available through the Million Veterans Program. And in particular, I'm going to be discussing about Mendelian randomization, with a particular application related to blood lipids and coronary artery disease, and how we can think about different study designs for Mendelian randomization, as well as their potential implications for bias. Again, this research is supported through the VA-CAUSAL Methods Core, as well as, which is this collaboration between the VA and the CAUSALab. So just to provide first an introduction to Mendelian randomization, this is an increasingly popular application of instrumental variable analysis, which leverages genetic data in order to estimate the effect of non-genetic exposures on an outcome. And really the big advantage here of Mendelian randomization or instrumental variable analysis more broadly is that in theory, we could identify causal effects without knowing or measuring the treatment outcome confounders. So a very classic example that we could think of here is looking at the relationship between LDL cholesterol and coronary artery disease. And we can think about potential genetic variants that are related to LDL cholesterol levels. These genetic variants could be involved in the metabolism or the transport or the absorption or any other factors related to LDL-related pathways. And under a certain set of assumptions, which we can refer to as the instrumental conditions, as well as a fourth assumption of either homogeneity or monotonicity, then we can presumably estimate some sort of causal effect. And so many of my colleagues have already discussed this target trial framework that we can think about in terms of analyzing observational data. But interestingly enough, this analogy of a trial has long been used to explain what Mendelian randomization is. And it's often conceptualized as a quote-unquote natural trial. So on the left, we can think about a potential trial where we randomize participants to either a statin or a placebo, which would have subsequent effects on their LDL cholesterol and then in turn their cardiovascular disease risk. And the idea is that this Mendelian randomization design is instead using this quote-unquote natural randomization that happens through the allocation of certain genetic variants, which subsequently also have effects on LDL cholesterol levels and cardiovascular disease. So the idea here is that somehow we're leveraging some sort of natural source of randomness in order to draw this analogy to a randomized trial where the randomization happens by design. Of course, there are many threats to this analogy between Mendelian randomization and a trial, and deconstruction of this analogy has really been discussed a lot in the past 5 years. And I'm going to highlight some of the main threats here. So the first is that I mentioned there are a number of assumptions that are required in order for us to interpret the MR estimate as a causal effect. And so if any of these conditions are violated, then our estimates would be biased. This is also further complicated by the fact that most MR studies are interested in exposures that are time varying in nature, and this also lends more complications to how we think about these different conditions that are required. The second is that in Mendelian randomization studies, we can think of the time at which participants inherit the genetic variants as the time of randomization. So in other words, randomization occurs at conception, but most MR studies, which generally require data from large biobanks, typically don't start follow-up until years or decades later. And so if we think about this in the context of an actual trial, we have these three elements that are aligned at a time zero. So this is when eligibility is assessed, when treatment is assigned, and then follow-up is initiated in order to ascertain outcomes. However, if we think about a Mendelian randomization study, we have this randomization or treatment assignment, which occurs at conception. But typically, eligibility and enrollment into a biobank, for example, doesn't happen until decades later. And so you have this lag that happens between the randomization and the start of follow-up. And this delay can introduce potential selection biases if any factors that are related to entry or eligibility into the biobank are also related to your genetic variants. So just as an example, if we're interested in cardiovascular disease as an outcome, but we're starting our follow-up in patients aged 50, we may have to restrict our analyses to people who have not yet developed cardiovascular disease, because typically we want a cohort that is free of the outcome at baseline. But this process can in fact introduce selection bias in the context of Mendelian randomization studies. And so in contrast, sometimes you may see that Mendelian randomization studies will actually include prevalent outcomes as part of their analysis. Part of the rationale is that in Mendelian randomization studies, we're looking at quote-unquote lifetime effects, and so we should include people who both already have the disease and those who may develop it in the future. The challenge here is that now we can trace an alternate path that is, again, another violation of an instrumental condition where we have this path from our genetic variant Z to previous diagnosis of a cardiovascular disease, which can have an independent effect on your future risk or your future prevalence that's independent of the actual exposure or treatment of interest. And so, like I said, this delay between the start of between randomization and the start of follow-up can create these complications where if we apply stricter eligibility criteria, which is really aligned with how we would classically think of designing this in the context of a trial, this could introduce bias. But if we choose not to apply those eligibility criteria, if we, for example, include participants with a history of the outcome, that introduces an alternate source of bias. The last threat to this analogy is that most Mendelian randomization studies are really conducted by what we can think of as meta-analyzing data from two different populations. So the idea is that I could get the gene exposure relationship from one study and meta-analyze that with the gene outcome association from another study in order to get a final estimate. In the context of a trial, that would be as if we took the adherence measure from one trial and then combine that with the intention to treat estimate from another trial in order to get a per protocol effect. So, you know, that's something that's, I think personally, I've never seen done in practice for trials, so it's a little bit strange to be thinking about doing that in the context of observational data. And so really this work that I'm about to share is trying to look at the empirical effects of these different threats to this analogy between Mendelian randomization and the trials, and look at their impact on the MR estimates that we can get from longitudinal observational studies. And this has really not been done in previous work, largely because we need to have a lot of longitudinal data with genetic data within a given sample. And so what I'm going to highlight here is how we use data from the Million Veterans Program in order to empirically evaluate the impact of different MR design choices, as well as the choice of 1 versus 2 sample MR. And we're going to look at this specifically in an applied example of LDL cholesterol and coronary artery disease. And so this Million Veteran Program is a longitudinal cohort and mega biobank that's nested within the Department of Veterans Affairs. By now, there have been over 1 million veterans who've enrolled, and all of the patients who've enrolled, their data are linked to electronic health records, so we have access to patient encounters, lab results, medications, et cetera. But these participants have also undergone additional data collection efforts. So we've collected, well, not we, but the VA has collected biological specimens and additional data from questionnaires that can help supplement these analyses. And so when we think about, so what we did is we first designed our index or our referent MR study. And the idea of this study was try to map some of the eligibility criteria as closely as possible to what it would look like in a trial of statins, for example. And so, for example, we would restrict this study population to those who don't have a history of coronary artery disease, as well as individuals who don't have a history of a statin contraindication. And so to emulate randomization, we used genetic variants related to LDL cholesterol across 3 different genes. Our exposure of interest was LDL cholesterol at the start of follow-up, and then we looked at the outcomes of coronary artery disease after 10 years of follow-up. We conducted all of our statistical analysis both using 1 sample MR, which means all of the estimates were obtained from our MVP data, versus a 2 sample approach where gene exposure relationships were pulled from a previous genetic study of lipids, and the gene outcome associations were estimated from MVP data. Afterwards, we then sequentially modified different components of the design of our MR study to evaluate how these changes in the study design would affect our estimates. So many of these decisions essentially reflects some common decision points that MR investigators face when they're trying to design an MR study. And some of these changes that we made were also made to reflect the UK Biobank study population because we wanted to compare our results against previous estimates from the UK Biobank. So in this design 1, this age restriction was applied to correspond to the UK Biobank population. Design 2 analyses were no longer adjusted for loss of follow-up, which again is very common in MR studies. In design 3, the outcome status is evaluated at the administrative end of follow-up. Again, this is very common where essentially everyone could be undergoing different durations of follow-up and their outcome is just evaluated yes, no at the end. The 4th is then we no longer exclude participations with a statin contraindication, and the last is that participants with prior coronary artery disease are no longer excluded. And as you can see, we wanted to compare some of these estimates from these different designs to previous UK Biobank published results. And so just in brief, you can see that in the end of our analysis, we had about 365,000 participants who were included in our analysis. On average, these participants were about 57 years of age at the start of follow-up. So that gives you a sense of the delay between randomization and the start of follow-up in the context of an MR study. And so what I'm going to show here are the estimates that we obtained first in our index design. So we saw an odds ratio of about 1.6 between LDL cholesterol and coronary artery disease. This was much more attenuated in our 2 sample MR, which was about 1.15. And I'm not going to walk through these next few designs in that much detail, mostly because we didn't see that much impact on the actual MR results. So we saw that regardless of these different design changes we made to the study, the estimate was largely the same. And when we compare these estimates to previous UK Biobank estimates, we can see that they're about they seem to be fairly compatible. Where we saw the most difference was in our last design, which determined whether or not participants with prior or existing coronary artery disease should be included. So we saw that once we included these participants into the analysis, the point estimate changed quite dramatically, and we saw an odds ratio of about 2.1. But interestingly, this is also very compatible with previous UK Biobank analyses that also included prevalent outcomes into their analysis. I won't go into this in detail, but we also looked at age-stratified estimates, and so as you can imagine, the confidence intervals were much wider, and there seems to be potentially some heterogeneity in the estimates across different age groups. And so in conclusion, what we saw from our MR analysis is that it supported a positive association between LDL cholesterol and coronary artery disease, but estimates ranged quite widely and appeared to be most sensitive to the inclusion of prevalent outcomes. Our one sample estimates were consistent with previous UK Biobank estimates, but the two sample MR estimates were much more attenuated to the null. And really what we were really interested in was how MR studies and trials can deviate. And this can happen in many number of ways. So the first is that MR studies often have ill-defined study periods and ill-defined durations of follow-up. This is often a result of the reliance on summary-level data in two-sample MR. And we can see that MR studies often include participants that have contraindications to the therapies that MR is quote-unquote trying to emulate. And so it's creating this tension between potential selection bias if you exclude them, but then you're not having an appropriate target population or what the trial population would look like if you included them. And the last is that participants with prevalent cases of the outcome are often included in MR studies, and again, it's creating this tension between different sources of bias, such as selection bias versus an exclusion restriction violation. And there are many other ways in which MR studies and trials can deviate, which we didn't go into as much within this particular study, but one thing that I want to focus on is that the treatment strategies in Mendelian randomization studies are typically very ill-defined. So when we talk about LDL cholesterol, what does it mean to have an effect of LDL cholesterol? And oftentimes we're thinking about some sort of ill-defined hypothetical intervention on cholesterol that we can't necessarily emulate using observational data. And so when we think about future considerations, this analogy between Mendelian randomization and trials is still very helpful because it can highlight some of our implicit assumptions. And depending on the design of the MR study, it can be vulnerable to different sources of bias. And so really having one sample data, such as from the Million Veterans Program, allows us to consider multiple approaches to assess the sensitivity of these estimates. And so I'd like to acknowledge the veterans, the MVP staff, and the many collaborators who made this work possible, as well as various funding sources. And thank you. I'd be happy to take any questions now.